monotherapy will not give any much. Midline sternal, chronic issues and acute issues. There are acute issues like superficial wound infection, deep sternal infection, mediastinitis. These are in less than 1% of the patient in most of the India. Hypertrophic scar, keloid, parasternal, paresthesia, frozen shoulder, cervical radiculopathy, incisional hernia, sternal osteomyelitis and costochondritis. These are the chronic conditions, and many of these chronic conditions comes with the chest pain, and sometimes post-operatively it is very difficult to whether the pain is arising from the heart or because of these chronic issues. So I thought that keloid, there is no proper treatment, so I should go through the literature, review literature, and then have an insight. So that's the reason that I decided to choose this topic to give on that. So basically, keloid is a non-cancerous fibrous proliferation that occurs in the dermis after trauma or injury to the skin. And keloid grow beyond the boundaries of the original wound site. So suppose there is a midline scar, it goes into parasternal site. The etiological factor that determine how a scar becomes keloid remain still unclear. So earlier literature date back to many century, 1700 BC, the Egyptian surgeon has described this, and after that Baron has described as pancreas, and later it was changed to keloid. But it was very confusing with the cancer, and that's the reason that now we call as keloid. So chile means a crab-like thing, and oid means like, crab-like. So the keloid grow like a crab, and that is the reason that now we call Keloid. The intranasal steroid therapy started in 1960s, pressure therapy 1970s, and topical silicone gel sheathing was introduced in 1980s. Before 1960, there was no treatment for keloid. You can go, if you see this is the patient of a gel patient, and he was assaulted with sharp object on the back, and he developed keloid. So around 2 million people around the world have open heart surgery every year, and out of this 0.5 to 5% of the patient have sternal wound issue, chronic as well as acute. Out of that, 0.2 to 3% patient develop mediastinitis, and 4.5% of the patients suffer some sort of scar issues like hypertrophic scar or keloid. Across the globe, if you see North America, Europe, Asia, the number of cardiac surgery is more in North America and Asian countries, and dark pigmented and Asian and Caucasian, they have a more prevalence towards keloid formation. Basic symptoms are usually pruritus, pain, tenderness, swelling, and secondary infection. Another thing is unhappiness. They are never happy with the surgery. They always blame that my surgery is not done fine. And they have a lot of psychological issues. And that's the reason that the counseling is most important in such patients, that you have to make them understand this is a skin issue, and it is because of your skin type. So basically, sternal issues, especially in the scar, there are main two things. One is keloid and one is hypertrophic scar. So how to differentiate that? The keloid and hypertrophic scar are two well-known type of excessive pathological scar. These types differ by aesthetic pathogenesis, histopathology, treatment, although there are overlapping characteristics in both. Compared to hypertrophic scar, keloids are categorized as more clinically severe in nature, pruritus and pain more frequently in patients. Classically, keloid scar appears slowly over a month beyond the initial wound ages, while hypertrophic scar typically develop over the period of week and stay within the initial ages of the scar. From the histological perspective, keloid include a random organization of type 1 and type 3 collagen fiber, whereas hypertrophic scars have organized pattern of type 3 collagen. Keloid progress to form a thick, firm scar but rarely heals spontaneously, unlike hypertrophic scar that can heal over a year. And since keloid can be distressing to patients, there has been great interest in understanding the key aspect of keloid pathophysiology. So if you see the difference between this hypertrophic scar occur in first few months, whereas keloid occurs after few months. Usually it is flat and spontaneous remission with the time, whereas it remains elevated from the baseline and it does not spontaneously resolve. Limited to area of original tissue damage, whereas it goes outside the original scar. Size related to injury, whereas minor injury may produce a large lesion. Occur with motion and tension independent of motion. But yes, tension is related with keloid. Tension means at the site of incision, there is a, when you suture back, the tension should not be there on the suture area. May be improved with appropriate surgery, but keloid, if you touch, it will reoccur or it will disfigure more. So these are the few things. Another thing is hypertrophic scar is not familiar. Keloid may be familiar. Hypertrophic scar doesn't touch any races, but black is more involved. The hyperpigmented skin is more labile for keloid formation. Female and male equally, whereas female are more prone, especially in earlier age group, childbearing age and lactating and pregnant female. You incise her, the chances of keloid development is very high. Borders remain within the wound, outflow outside the wound. Naturally, site flexor surface usually hypertrophic scar occurs, whereas sternal, shoulder, face, especially earlobe, and the piercing site. These are the few differentiating points. One of the articles recently only I read that whenever there is any scar, you have to identify the Van Cooper scar scale. There are total 6 parameters. One is pigmentation from 0 to 3, pliability, stretching, 0 to 5, height from the baseline, how much it is elevated, then vascularity depending on pushing a pressure, whether it is vascular or not, that you will come to know. Pain, how much pain is there, and pruritus. Based on this, evaluation should be there in whatever therapy you give to the patient. So, keloids, it gives significant emotional, physical distress to the patient if it is inadequately treated. And cardiac surgeons are never interested in, once the surgery is done, they are not interested in keloid. They will refer to plastic surgeon or general surgeon for management of keloid. If you see the keloid pathophysiology, mainly there are patient factor, topographic and environmental factor like ethnicity, genetics, age and hormones are related. The topographic factor like increased tension in the suture site, sebaceous gland present in suture site with oily skin, the presence of follicle, hair follicle, that is also one of the topographic features. Then extracellular matrix and macrophage, increased viscoelasticity, non-glabrous skin. These are the topographic factor and environment factor like you put an incision and then the spontaneous keloid also can present on these areas. That is either because of mild scratching or some trauma or little bit small burn, or in any sort of inflammation. So there is an abnormal cellular response, and because of that there is a fibroblast increase in number, proliferation and sequencing and apoptosis, increased migration, invasion, ECM synthesis and deposition, ECM degradation decreases, increase the metabolism, and very complex this one. And keratinocytes also play a role, then myofibroblast and endothelial cell, and ultimately basically there are two things more important, that is TGF-B1 and TGF-B, B1 and B2 and B3. These are the important pathophysiology. Keloid scar, there are few emerging therapies and few classic current therapies what we have at present. So one is adhesive tape support, silicone based product, pressure therapy, surgical excision, corticosteroid, cryotherapy, radiotherapy, laser therapy, 5-fluorouracil and imiquimod therapies. But there are few, another one is interferon, bleomycin, mitomycin C, then botulinum toxin, tamoxifen, growth factor, AC inhibitors, calcium channel blocker, onion extract, light therapy, stem therapy, genetic and epigenetic therapies. Few, I got some literature, but few I don't have. So whatever I got, I am putting into this presentation. So what is occlusive therapy? Occlusive therapy means there is a silicone sheath available in the market. Okay. Now we don't know what is the exact reason that how it reduces the keloid. But commonly used, it is commonly used since 1960s, 70s, and it reduces the risk of excessive scar formation. So it should be applied whenever you find there is a development of little bit hypertrophic scar, and immediately you should start applying. It is composed of semi-occlusive silicone gel sheet combined with durable silicone membrane. The prominent mechanism of action of this dressing is unclear, but theoretically it is act as a hydration and occlusion of wound bed. The scar tissue has been shown to be more prone to transepidermal water loss, possibly reflecting decreased water barrier function of the sternum cornea. This silicone creates a moisture retaining environment that prevents dehydration and sternal of the sternum, the skin layer, but it limits activation of fibroblasts and subsequent collagen production. But if because of the high temperature zone in our country, there can be a chance of infection, like bacterial abscesses can form. We use very regularly this whenever we suspect any patient is going for developing a keloid. So initially only we start. So this is the Amazon picture. There are sheets available online also, and professionally some few very costly scar sheet also available. So you have to apply, and that can last for 6 weeks to 4 weeks. Again, I have to apply. And along with the chest binder, this gives fantastic result. So this is for a sternal wound. It is quite long. So we usually ask the patient to purchase this and we apply. So compression therapy. It is
a sort of preventive measure for you.
It's a preventive measure. And another thing is, suppose you have a hypertrophic scar or keloid and you have gone for excision therapy, surgical excision, and after that you put a steroid therapy as well as apply the skin. So you have to use monotherapy will never work in keloid. So you have to use 2 or 3 combination therapies. So either after excision therapy, or once you identify there is a keloid formation is initiated, you start giving that. You cannot give to everybody because the badana nathi aata. So compression therapy is basically you are giving pressure on the wound. It is adjuvant to surgical excision to prevent recurrence of keloid. So what we do is we give elastograph bandage to most of the patients for radial wound and the leg wound. So that is basically one type of compression therapy. So basically how it acts? It acts as a mechanoreceptor induced apoptosis of the cell in the ECM and or pressure induced ischemia that alters the fibroblast activity and promote collagen degradation. The compression treatments are either elastic bandage, custom pressure, mold, or there are magnets also available for the ear keloids. Studies have shown that non-recurrence rate of 70.5 to 95%. Similar occlusive dressing therapy, compression therapy has a best result if the pressure device is affixed for at least 12 hours per day for at least 6 months at a pressure of 24 mm of Hg. But if you use exceed pressure more than 30 mm of Hg, it can cause tissue necrosis. So one good thing about a keloid is those who are prone for keloid, they will never develop the wound infection. Because the tissues are like that healing will be more. So I have never found any patient who develop keloid and have a mediastinitis or superficial wound infection. They always have a good healing. There are pressure garments available in the market. This is basically a gynecomastia jacket, but which normally we use if patient wants pressure garment, or you can use undersize waist underclothes. That also we can use. So normally in post-operative we usually give chest binder that normally works in most of the patients. We ask them to continue that chest binder for basically chest binder is meant for sternal stability. But we give if the patient develops something like this, so we start giving silicone gel, steroid as well as pressure for 6 months or 9 months. Then comes the intralesional steroid. So this is the most accessible and efficacious keloid therapy. The intralesional steroid continue even now that it is a first line treatment for many physicians. Typically triamcinolone injected in a concentration of either 2.5 mg to 20 mg for facial keloid and 20 to 40 mg for non-facial keloid. Steroid act by suppressing the wound inflammatory mediators and fibroblast growth while increasing the collagen degradation. The therapeutic response rate of intralesional steroid therapy is very variable. Sometimes it works, sometimes it doesn't work. When it works, when you do it early, it works fantastic. But 2 years after the keloid formation and the more fibrosis and it is grown overboard, and after that you put a steroid, it might not work. Partial side effects.
So, sir, how can we decide the keloid is actively growing or not?
Usually 6 months to 1 year, that is the time. But once it is developed, okay. I get every year around 10 to 15 patients that I have operated in 12, 15, 16 and keloid is there. I have gone and so lot of patients, now what to do. So I also suggest that you have to consult a plastic surgeon, go for excision therapy and skin graft as well as a silicone, steroid, and multiple therapy at the time, and most of the patient does extremely well. There are one plastic surgeon, I don't want to give name because of the near Nilamba circle is practicing, young guy, very energetic. He has got good laser, good pulse guard laser as well as CO2 laser, YAG laser. And I have sent 3 or 4 patients in couple of years, last couple of years, give excellent result for keloid. So what we do is basically this award product, Keloid. We inject with the keloid. We have to use insulin syringe, and suppose this is a keloid. So we have to start from periphery. And even with a small keloid, you have to use every 2 mm or 4 mm, just one. Basically, the blanks should develop inside the keloid. And when there is a long scar, in that case, what we do, first time when we give intralesional steroid, we make a sheet, okay, and mark 1 centimeter, 2 centimeter, 3 centimeter in the paper, and then we give zigzag, because every weekly we have to give for 6 weeks. So one time we have injected one side, the other side opposite, and this. So every time you have to mark, so result will be optimal. What will people do? Just inject. Injecting just like that, it is not going to help. And most of the patients, early stage, they subside. At least the pruritus, pain, redness, tenderness, they all go, and it becomes at least flat. Then the topical imiquimod. It has been used for a basal cell carcinoma and human papilloma virus related warts. 5% cream are available as an adjuvant therapy for keloid after excision. So it is basically toll-like receptor 7 agonist that limit the fibroblast production of collagen by increasing the local concentration of interferon alpha 1, and has been shown to decrease fibroblast activity in a dose-dependent manner, reduce glycosaminoglycan production, and increase the collagen level. The common side effects are hyperpigmentation, erythemas, irritation, secondary infection, and typically resolve with upon suspending the therapy. So after some 4 to 6 weeks, it becomes normal. So this cream is available in 411 rupees in NatMed and many other online pharmacies and most of the common pharmacies. Then the topical mitomycin C. It shows to reduce the scarring after ophthalmic, tracheal and laryngeal surgery, and it can be used to reduce the keloid recurrence post-excision surgical therapy. Basically, mitomycin C is an anti-neoplastic derivative of streptomycin cespitosus, and it inhibits the cell proliferation. Mitomycin C shown in vitro study the adult dermal fibroblasts to decrease fibroblast proliferation at a concentration of 0.4 milligram per ml and 0.1 milligram per ml. The application of this, how to apply? So there is a vial available. You have to soak any gauze piece, and it is to be applied 3 to 5 minutes, and every 3 weeks you have to reapply. The common problem result in ulceration and hypopigmentation and post-treatment pain. So mitomycin C is also available in IndiaMart and many other pharmacies. Approximate cost is around 410. Then there comes the intralesional and topical 5-fluorouracil, and it is a basically pyrimidine analog that irreversibly inhibits the thiamine synthesis, leading to disruption of DNA replication and cellular proliferation. It has shown the reduced fibroblast growth, induced fibroblast apoptosis, and decreased PGF-B driven collagen synthesis. Reported to have 21 to 35% of recurrence in minimum of 3 months and maintain the keloid volume reduction of keloid for at least 6 months after the last therapy. So none of this therapy has given 100% result. So and there is no review article or RCTs are available. These are the cream available. There are many companies make this. The creams are available. These can be used. And injections are also available. And the cost of injection is just less than 15 rupees a vial. The side effect is usually a pain at site, wound, ulceration, hyperpigmentation, after intralesional 5-FU therapy. The known side effect of 5-FU therapy like anemia, leukemia and thrombocytopenia are not observed in series. Then comes the interferon. Interferon is a composed of a group of cytokines that mediate the complex cellular interaction, including immunoregulation, anti-fibrotic activities and anti-proliferative functions. This interferon alpha 2b and interferon gamma has been evaluated as a therapeutic treatment option for keloid. This has shown suppress the collagen synthesis and scar contraction by fibroblasts. Interferon alpha 2b has been described to be injected at least twice into keloid at a dose of 5 lakh to 6 million units. The one study reported 18.7% keloid recurrence and evaluated injection of 0.1, 0.01 milligram frequency and 1 to 3 times per week for 3 to 10 weeks. The side effect like influenza-like symptoms for fever and myalgia, you can give acetaminophen for side effect. It is also available in an injection format. The cost is almost 850 rupees, and with that you can give 2 or 3 injections. The bleomycin. Bleomycin is a glycopeptide isolated from Streptomyces verticillis and predominantly used as a chemotherapeutic agent, but it has been studied in keloid and hypertrophic scar. The bleomycin has been shown to suppress collagen synthesis by dermal fibroblasts, increasing the collagen turnover and decreasing the level of lysine oxidase required for collagen maturation. So how it is used? Either it is used as a tattooing therapy. The tattooing people, what they do is there is a micro needle, in that there is a dye they inject. So the same machine they use, instead of dye they use bleomycin. That is called tattooing therapy. There are modern machines available like dermojet and intralesional injection. For this, 3 days back I have discussed with one of the cosmetic dermatologist that what is all this. He said that there are almost like cardiac surgery, there are a lot of new equipment which is very costly, is now available in the market, and so he was describing the dermojet and intralesional injection plus or minus combination of electroporation therapy. Bleomycin tattooing protocols are there. First dripping means injecting inside the keloid with 20 to 25 gauge needle. 70% scar flattening occurs. Recurrence rate is 14 to 28.6% between 10 to 18 months. Few studied use the bleomycin intralesional injection to treat the steroid-resistant keloid using dermojet divide, and this group administered treatment at an interval of 4 weeks until favorable aesthetic result or symptom reduction were achieved. These reported 73% of the patients achieved complete flattening with 0% recurrence after at least 16 months, with patients receiving an average 3.8 sessions per keloid. So this is the only one therapy which gives promising so far. The common side effect is hyperpigmentation, pain at injection site, dermal atrophy, and hyperpigmentation with application of topical retinoid can be used to help the patient with the hyperpigmentation. So this is available in the market, bleomycin injection. I am going to try this whenever now next patient comes. I will take to a tattoo center, sterilize it, and I will give. At least for trial I will do that. This I was not knowing until I have presented this, because few days back only I started reading on this. Surgical technique. There is no technique in that, but still there are some considerations. They rarely used as a surgical alone therapy, as a monotherapy. The recurrence rate is 45 to 100%. So classical teaching is that don't touch keloid. Surgeons always say keloid is there, don't excise. general recommendation for primary closure is following complete excision, gentle handling of the tissue, avoid any wound bed tension, eversion of wound edges to be avoided, meticulous approximation of the wound edge, adequate control of infection and bleeding. These are the, whenever you are doing the first time, at that time only you have to do all. And even if you exercise, so to reduce the skin tension, what they do is they exercise and then they put a full thickness skin guard. So Gigardi has described the full thickness skin graft from the exercise keloid skin with no recurrence at least at 6 months. So there are like bilateral or dermal skin replacement, Integra is artificial skins also available with neodermis with subsequent epidermal skin grafting. Complex type of therapies are also there, but they reported no recurrence at mean follow-up of 38 to 60%. But these are not standard data because I think this particular thing is funded by that company, and that is the reason that they are giving, because we have never seen any patient who has complete, there is no recurrence. So cryotherapy, basically liquid nitrogen is used as a freezing therapy for keloid to reduce the scar volume and recurrence. During this cryotherapy, temperature of the keloid is lower to minus 22 degree. Lower temperature suggests that reduced vascular damage resulting in cell anoxemia, cryonecrosis and coagulative necrosis. It gives several significant changes in scar tissue structure. Post-treatment scar biopsy demonstrated the reorganization of collagen fiber into more compact parallel fashion comparable to classic scar and resultant dermal collagen structure. Keloid tissue exposed to cryotherapy has been reported to reduce myofibroblast, reduce mast cell reduction in production of TGF-B by dermal fibroblast. But again, recurrence rate is around 0 to 24% and 6 to 18%. Common side effects are intralesional therapy, temporary lesion, blistering, mild to moderate post-operative pain, and temporary hypopigmentation. So these are the main problem. The most important problem is the hypopigmentation. Then the radiation therapy. The most effective as an adjuvant therapy after surgical excision compared to monotherapy. The mechanism of action of radiation is not known. In vitro study of radiation therapy has demonstrated increased rate of premature mature cellular sequences of keloid fibroblasts and decreased proliferation in post-dose dependent fashion. Basically, X-ray and electron beam radiation therapies are used either low dose or high dose. Low dose rate and high dose rate. The high dose has got a good reduction rate, but low dose does not give that much good result. The recurrence rate again reported from different literature 2 to 72%. The problem with that is erythema, disquamation, and transient change in pigmentation. Another long-term patient might experience permanent dyspigmentation, depigmentation, atrophy, telangiectasia, subcutaneous fibrosis, chronic wound, and possibly radiation-induced malignancies. Then comes the pulse diode laser, that is PDL, is a form of non-ablative laser therapy to target the keloid microvasculature to improve the scar appearance. The PDL was initially engineered to treat vascular lesion by adjusting the waveform of laser to 585 to 600 nanometers, specifically targeting the hemoglobin and oxyhemoglobin as a chromophores. With respect to the keloid pathology, PDL is thought to cause microvascular damage that result in local hypoxia and decrease in nutrient supply, which serve as a catalyst for several biochemical changes within the scar. Again, the The therapy offers 12 to 18 sessions required over a with 4 to 6 week interval, and the recurrence rate is still in that also very high. But what you can found in one literature, 55% improvement in Vaghela scar scale after 6 treatment with less improvement seen in the older scan. The common side effect of PDL therapy in the scar include temporary purpura, blistering, crusting, and post-inflammatory pigmented changes. Then there is a ablative laser, that is carbon dioxide and YAG laser, and it basically targets the water molecule to cause local tissue changes, including the collagen remodeling, increase the level of basic fibroblast growth factor, and decrease level of TGF-B. And there are evidence that multiple ablation with CO2 is necessary for longer lasting scar improvement. However, the YAG laser is not much investigated. There are very few studies are available. The ablation to reduce the scar redness, scar elevation, scar hardness on average by 50% can be achieved with this. The common side effect is erythema, edema, and hyperpigmentation. Then laser assisted drug deliveries are also available. Means you give laser as well as intralesional therapy with they use CO2 and YAG laser and along with the other topical agents. Then there is a suddenly new thin scale platelet rich plasma are used for keloid. The PRP is a concentrated autologous plasma that contains supraphysiological level of platelet alpha granule with the growth factor cytokines such as vascular endothelial growth factor, platelet derived growth factor, and TGF-B. It works as with the dermal fibroblasts have demonstrated that PRP increase the fibroblast proliferation, expression of collagen, matrix protein synthesis. Increase the level of TGF-B in PRP has been proposed to activate the negative feedback mechanism in the TGF-B signaling pathway. Basically, usually it is used post-surgical excision therapy, and that is injected into wound bed. The conclusion is that the breadth of therapy available for prevention of treatment of keloid is continuously expanding, with the encouraging recent progress from novel strategies. As a clinician, become more familiar with the use of different injectable treatment and device described in the literature. Reliable data can be gathered regarding their consistent use. Currently, there exists no standardized guideline for keloid management endorsed by governing academic bodies. The presence absence of large, high-quality studies evaluating the efficacy of different keloid modality restrict the establishment of standardized guidelines for keloid management. The desire for a higher level of evidence to guide keloid management for all physicians is echoed in most of the current literature as well as by our study population. Currently, there are no high-quality randomized controlled trial and few low-quality RCTs evaluating different keloid treatment. Retrospective cohort, prospective cohort, and systematic review compose the current evidence for majority of keloid therapy. Durrani has noted the poor methodological quality was a common reason that decreased the level of evidence provided by several non-randomized comparative studies. Designing a reliable study to investigate keloid treatment requires standardization of experimental method, not currently seen in the literature. There is no consistency among the current study to exclusively study keloid instead of mixed hypertrophic and keloid scar population, or to have consistently mean by which to evaluate the therapy success. When evaluating the keloid therapy, studies should consistently use validating tools for scar assessment like Vancouver scar scale or modified by Vancouver scar scale or patient and observer scar assessment scale. But none of these studies use this type of scale. Additional studies should make an effort to include the subjective measure of reduction in scar volume. A consistent experimental design is necessary to perform comparative studies between the treatment modality. Keloid continue to be a challenging pathology for clinicians, surgeons. Further treatment regime must be based on high quality studies and replicable improvement in the outcome. Thank you so much, sir.